This is a video technique for an anatomic reconstruction of the medial collateral ligament and the posterior oblique ligament with allograft for high-grade valgus laxity. The disclosures for the senior author are listed. The patient is positioned in the supine position on the operating table and induced under general anesthesia. A knee exam including valgus stress testing and extension and 30 degrees of flexion and anteromedial rotation via the anteromedial drawer test at 90 degrees is performed to validate the clinical exam findings. An anteromedial incision is made from over a previous knee incision, but usually occurs at the midpoint of the vastus medialis oblique muscle to just distal to the tibial tubercle, splitting the distance between the anterior tibial crest and the posterior medial aspect of the tibia. Dissection is then carried over the medial aspect of the tibia. A spinal needle is placed at the joint line, and the native distal tibial attachment of the MCL is located 6 cm distal to the joint line. This location is marked with a methylene blue marker, and a guide pin is drilled across the tibia using the collateral instrument tibial guide. This guide pin is overreamed with a 7 mm reamer to a depth of 25 mm, leaving the opposite tibial cortex intact. A passing stitch is placed, and the distal aspect of the tibial tunnel is notched. Next, the site for the POL tibial tunnel is approached, just distal to the anterior arm of the semimembranosus tendon. This location is marked, and a guide pin is drilled perpendicular across the tibia using the collateral instrument tibial guide, exiting at Gerdy's tubercle. The guide pin is overreamed with a 7 mm reamer to a depth of 25 mm, and a passing stitch is placed. Attention is now brought to the femur. The adductor magnus tendon is identified first to identify the adductor tubercle. From the adductor tubercle, measuring 12 mm distal and 8 mm anterior helps to identify the medial epicondyle. The MCL femoral attachment is located just posterior and proximal to the medial epicondyle. A guide pin is drilled anterolaterally across the femur at this location. Next, the femoral attachment of the POL is identified. A smaller thoradomy is created to separate and lift the posterior medial capsule at the attachment site of the POL on the femur, located about 7.7 mm distal and 6.4 mm posterior to the adductor tubercle. A guide pin is drilled through the POL femoral attachment, parallel to the MCL guide pin. At least 9 mm between the pins is required to maintain a 2 mm bone bridge between the tunnels. It is very important to pass both guide pins and verify that they are both in the desired anatomic location due to their proximity in case one or both the pins need to be repositioned. Next, both guide pins are overreamed with a 7 mm reamer to a depth of 30 mm and passing stitches are placed. The MCL graft is prepared from a tibialis anterior allograft and is 16 cm in length, and the POL graft is prepared from a semitendinosus allograft and is 11 cm in length. Both grafts are whip stitched at each end with number 2 non-absorbable suture. The MCL and POL grafts are then passed in their respective femoral tunnels and fixated with 7 by 20 mm bioabsorbable screws. It is important to pass both grafts into their femoral tunnels prior to fixation of either one because the proximity of the tunnels may result in the initial interference screw impinging on the second graft tunnel, which would interfere with graft passage. Soft tissue channels are made from the femoral MCL and POL tunnels to their tibial tunnels. For the MCL, a channel is made under the superficial sartorius fascia between the two reconstruction tunnels. For the POL, a channel is created under the posterior medial capsule layer. Both grafts are passed through these channels and passed in their respective tibial tunnels. The MCL graft is fixed first in the tibia with the knee at 30 degrees of flexion with a slight varus reduction force and the knee in neutral rotation. A 7 by 20 mm bioabsorbable screw is used for fixation distal to the graft at the previously notched position in the tibial tunnel. The POL is fixated with the knee in extension with a 7 by 20 mm bioabsorbable screw. This final fixation eliminated the patient's valgus gapping and anteromedial rotation. To reconstitute the proximal soft tissue tibial attachment of the MCL, a Q-fix anchor is placed 15 mm distal to the medial joint line. The MCL allograft is sutured to the Q-fix anchor with the knee in 30 degrees of flexion. Knee stability with the restoration of the valgus stress and anteromedial drawer test is validated one last time. The tourniquet is let down, the deep and superficial tissues are closed with suture.